dislocation reduced. So that is my point of view. But we have a protocol here where I work, where we take these patients to an early CT as soon as possible and plan for a definitive surgery as early as possible. For the failures that we have seen in reducing them close and ending up opening them without having been prepared. So we are prepared to handle these patients. So we did a CT immediately and planning to take him up for an early surgery as soon as possible. As we discussed, the skin was normal, the swelling is moderate, distal neurovascular was normal. So these were his CT scans. We can see that there is a dislocated talar head and part of the neck. There's a neck fracture, obviously, which is comminuted. There is a comminuted fracture of the body of the talus, and obviously medial and lateral, both sides are comminuted. So is this classifiable, Dr. Sampath, in your opinion? Is it important to classify this kind of injury? Can you classify it into any kind of, does it give you a prognostic way of mentioning what kind of an injury is this in terms of the classification? Is it important?
Basic classification is it's involving the body. So rather than talus neck, I will first classify it as a body fracture or neck fracture, because that is definitely going to tell you that a body fracture will have more chances of arthritis. And of course, it has dislocated from talonavicular joint as well. Obviously, a classical description that it goes from ankle, subtalar and talonavicular. It has not happened here because it looks fine in ankle, but has definitely gone out of talonavicular joint. So it's little rare, but it's there now. Not very classical to classify in class 4 of talus neck, but basically I will like to see from approach point of view and from prognosis point of view, if it is a body fracture, then I will like to see whether there is a dorsomedial comminution of neck, and then of course involvement of the joint.
Yeah, sure. So this is kind of an unclassifiable. Body classifications, anyway, I believe are not that good in literature. The talus body fractures, the neck fracture classifications are described. So it's a fracture comminuted neck, obviously, to classify, and the body as well. So it is both. So differentiation, we know from the neck to the body is a fracture line extension, the lateral talar facet, the lateral joint line, the lateral extension of the fracture line. But in this case, there is a body combination and then the talar head is dislocated. So I guess it's not classifiable. So that is the picture we have now. So this is what we have. So Dr. Fraser, can I bring you in? What would be your approach if you want to do an open reduction for this kind of approach, of this kind of a fracture? How would you do this in your hands?
So I'm still a fan of the dual incision approach. I have, however, in the last few cases, I have moved to just doing a single medial utility approach, which is likely to be the one I would use for this one, because you've got access to. The difficulty will be getting through to the talar body, but you'll certainly get access to the neck to get it reduced. You may end up having to do a medial osteotomy, medial malleolar osteotomy, if you want to do any more. But I think in this early stage, when you've got the CT information, I've talked about this before, that the evidence doesn't supports that you can delay your definitive surgery for up to 2 weeks without any compromise. The key is, as you said, is to get it reduced. So my inclination would be, if it does need opening, to reduce it, I would do a medial utility approach to get the head back in. And then if you've got enough information and you feel happy about it, and you're the surgeon doing it, and you're competent to do it, then I think you can carry on. But if you're a general surgeon, I think that's a sensible approach. It's a common approach. It's relatively straightforward to do. You're not doing harm in terms of future planning. So I think that would be my approach for that.
So a medial utility approach, when a comminuted fracture, how would you address the lateral side injury? Because there is a lateral dislocation of the talus head. It is not on the anterior or medial side, it's gone laterally, and there is a combination on both sides of the neck.
Yeah. So Balvinder, I think I will go with the two approaches, because the combination is there and the reduction from a single, even with the medial utility approach, even I do a medial osteotomy, then still it might be difficult because lateral side, more or less, most of the time it is not being that comminuted. And unless we see the lateral side, it's very difficult to tell whether it is properly reduced or not, considering the CT scan pictures.
Okay, so there's an option of doing a dual approach with a medial or a medial utility approach with a medial malleolar osteotomy. So I would like to run a short video if it can transmit. We have got a good bandwidth here. Can you see the video clearly?
Yeah, video is very clear.
So that's a lateral approach, and this is the medial approach from the medial malleolus to the between the tendons of tibialis anterior and posterior. That's where the talus head and neck should have been. K wires for the medial malleolar osteotomy, parallel wires, and then the plane of the osteotomy has to be exactly perpendicular to the K wires for future fixation. So that is how we decide. The site of the osteotomy has to be accurate in terms of exiting into the joint there. Pre-drill the wires and then keep one wire inside, start the osteotomy up till the wire that keeps you the correct angle, and then remove the wire with a broad blade osteotome. We complete the osteotomy and flip the medial malleolar fragment distally. Apply a distractor. We can use the pin and the calcaneus to retract the medial malleolar fragment with a vehicle into the drill hole, and then whatever is possible to reconstruct. I think believe in cases of comminution, a lot of fragments, smaller, will have to be removed. Larger fragments, we pick them up and fix them with cannulated headless screws, or if you're using small headed screws, then they have to be countersunk. Then on the opposite side, we use joysticking to reduce the talus head and neck, and then on that side, we could see the fracture line clearly. Provisionally fixed the neck after having reduced the body fragments. And then because it was comminuted on both sides, we used a small fragment plate. And that is the graph taken from the distal tibia onto the medial side of the neck. So that is the body there, and this is the neck area. A plate on both the sides was used. And that is the immediate post of X-ray. The subtalar was not very stable, so we kept a couple of K wires for 3 weeks. And that's about 6 weeks down the line, about 3 months, 6 months. And that's a year down the line. This obviously has healed. The patient is walking. There appears to be no avian at the moment, but obviously there are signs of a subtalar arthritis there, obviously, but doesn't have significant pain at the moment. He's managing well. And this is his range of motion. That is dorsiflexion and plantar flexion. That's about 1.5 years down the line. This slight limp, but he's managing well. Obviously, he's going to need subtalar fusion in some time in the future. So that's what we did. Opinions from the house are invited for the first case, SWARNENDU.
Yes, that was excellently done. But because I always choose for this sort of comminuted talar fracture, I'm always choose the two approach, because otherwise I cannot. If I don't see the lateral side, because lateral side I reduce it, and medial side most of the time it is comminuted. So I am very much sure that if I do the two approaches, I am confidently I can fix it with the plate on the lateral side, plus minus plate or screw on the medial side.
So Nendu, what's your tip or trick for getting the alignment right when you have a comminution and you are aligning the distal part with the proximal, the neck part of the fracture basically? Yes. If you have comminution on both sides, it sometimes becomes very difficult to get the correct alignment in terms of varus and rotation.
Yes, that is always the problem, and most of the time the lateral side is less comminuted than the medial side. So that's why I am my choice is more towards the two approaches.
I believe the literature says that there is medial comminution much more than the lateral.
Yes.
But I would say if I have done about 10 had lateral and 10 had medial comminution. So you have to be looking at the comminution
joint. Yes, also you have to look at how the subtalar joint is coming, and also you have to check and recheck in your CR picture how the subtalar joint is sitting on.
Yeah, that's true, but it becomes difficult sometimes in cases of comminution, bad comminution on both sides. If you have a less comminuted area or something which is not comminuted, you have fracture spikes on one side to guide you. But if you have comminution or if the fracture is distal, a bit distal, where the head part is small, then the alignment, the rotation, and the varus becomes difficult to judge sometimes. Dr. Fraser, you have any tricks or any tips from your side, any tricks how to assess the correct rotation in these cases?
I think this is the most difficult, but when you're describing, I mean, as has already been said, when the lateral side normally is not comminuted, but as you point out, when it is, that's when it's really difficult to get it right. And I think it's just about soft tissue balance and really getting a feel for the soft tissues. Even with distraction off a little bit, you can get a feel for where it wants to sit once you've got it reduced. I don't think there's any good advice otherwise.
Yeah, somebody want to say something or somebody?
Yeah. What I do in communicate like this is temporarily fix the talonavicular joint and body in subtalar joint across what you have done across the subtalar, because then you can align the neck which is comminuted. So many times they go in hyperextension, like distal femur, they go in hyperextension. So you must see that if you are aligning, I just pin across talonavicular joint after reduction and then pin across the subtalar joint after reduction, so that comminution is indirectly held in place, and definitely you are in not varus and as well as hyperextension at the neck. So that helps you to kind of get the reduction in comminution.
Yes, Dr. Rajiv. Yes,
Can I?
Rajiv.
Yeah.
Yes, Rajiv sir. Rajiv sir, go ahead.
So knowing the rotation of the body is not difficult. It is the rotation of the head part which is difficult. Because
Yes.
body, you have a larger facet on one side, smaller facet on other side. And body is poised between two articular surfaces. So that is not a big deal. So as Sampat said, I always like to make body into one piece, fix it with the subtalar joint, and then talonavicular joint fixed with one K-wire, and thereby you're making both the pieces one with intervening bone graft. The only thing which I do differently than what you did, Balvinder, is that I like to put a quadrangle frame for fracture talus, where I put my frame first, unlike you did. I put my distraction first. It makes your life very, very easy. And my distraction is in the form, I put in a posteromedial and a posterolateral pin into the calcaneus. And I connect it with the two vertical pins in the tibia. This gives me two advantages. Number one, it lifts the whole foot vis-a-vis the opposite side. So my imaging becomes easier. That's one. The second thing, these are the strong holding pins, so I can give a better traction. And the third important thing, whenever I am doing an osteotomy, no rod comes in the way. So that's what I do for all my fracture talus.
So I apply the distractor after I've completed the osteotomy, and then once the reduction part comes in, that's the time when I use the distractor in place. Anyway, so that's what we did. So should we be
Sir,
going
before
for
you proceed, Dr. Rana, sir, before you proceed, just a quick question from the audience. We'll take one question. Dr. Binu Alex has mentioned, he's asked about your plate size and screw size for the talus. So could you answer that, please?
That's a 2.7 mm locking synthesis plate, 2.7 millimeter.
Okay, fine. I think there are also matrix foot and ankle plates coming up for the Indian version. I think they're also pretty good enough. Your take on that?
I haven't used matrix plates in mine. I've only used this
All the plates which I have used in fracture talus, they are all matrix plate.
Yes, matrix foot and ankle system is very good. Very good system.
It works well.
Yeah, it's a good system. So please proceed to the next case.
Okay, so the next case is, and this is the one we want to discuss. So this is a 30-year-old male, and this is on the day of injury. Had a roadside accident, and that is presented in the emergency to one hospital, not to our hospital on day one. This is a policeman by profession, and that is the injury. So Who wants to take it up? Dr. Nirmalya?
I think we'll ask Dr. Rajiv Shah to take it up.
Okay. So I would like to know about the soft tissue status.
Yes. The soft tissue status is okay. It's not that was as history, because I did not see this patient on day one, but he said there was some swelling, but there was no compounding. There was swelling, but there was no blisters or something.
Yeah. So typically this, to me, in a young adult patient who has got no other comorbidities, is a case for surgical intervention once the soft tissue is settled. If I feel that soft tissues are not good enough, I would span, and while I would span, and before I scan, I'll do spanning. I might use my digital pressure to reduce the metatarsal basis which has come up, and I would span, and once the wrinkles are seen, I would go in and operate on this patient. If not, if everything is smooth, maybe I could wait for 4 or 5 days max and then could go in and do the fixation. But this to me is a frank injury in a young adult patient, requires fixation.
So would you be doing a fixation or a fusion?
Okay.
That is always the problem. Always the problem.
Yeah. So, well, I'm going to go ahead with fixation and not fusion.
I think we can take the opinion of Dr. Harold.
Yeah.
I love this debate. So this is a debate that's going on in the UK. I think we're trying to set up a trial at the moment. So I trained in Sheffield and we used to do bridge plating for these. I have now moved my practice almost universally to primary fusion of the medial column. I think it gets people back to work quicker. And obviously this is purely medial column in that, so I'm looking at the first, second and third rays. And I would leave the fourth and fifth mobile, probably K-wiring them temporarily. But I've tried bridge plating and patients have come back saying, well, I still can't work. I've ended up fusing them, they've lost their mortgage, their job. And so my feeling is to go with what the Americans do with their young, fit athletes, is fuse them and get them back to where they should be playing. These were useful joints a couple of million years ago. They're not useful now.
Yeah, so I agree. So possibly the word is leaning a bit more towards primary fusion of the medial rays. Is kind of injuries maybe. So, but this is what was done on the day of injury. Comments, Dr. Sampat, Dr. Nirmalya, Dr. Swarnendu. This is what was done on the day of injury. Would you ever use K-wires for this kind of injury with this?
No, it is not recommended at all. It's not recommended at all, because you have to understand the injury, because this is very, very unstable injury, and medial side always you have to fix it properly. It has to be hardly fixed. And lateral fourth and fifth, this is for the non-foot guys. It has to be always mobile. Never give any hard implant on the fourth and fifth ray. And always the first, second, and third has to be fixed nicely. Otherwise, this is going to fail. And K-wire is not intended for this sort of leg injury. This is my take.
And it is not even reduced. And it is not even reduced. You can see the places. The word, as far it goes, the wrist franks, on the early days, the joint and the ligament, it is not even reduced. There is a laxity and gap.
Yeah, that's true, Dr. Amitwa. So it's unused, it's not fixed at all. So it is a disaster, basically. But
It's a disaster.
If I'm not mistaken, Lis Franks was a guy who was a gynecologist and who used to do an amputation within 2 to 5 minutes, because he knew this joint, how stable this is. If you can ampute from this joint, then you could have ampute foot very early. If I'm not mistaken, FRASER can say that was the starting of the Lis Franks name, the Lis Franks injury. So that is the joint which is very important, and that has to be reduced.
Yeah, that's true, I believe. That's true. So, at 6 months...
Sir, can I do a quick comment? To Dr. FRASER, Harold, sir, you just mentioned that you do primary fusion for this kind of Lis Franks injury, first and second and third. So is there a study comparing plate fixation, primary osteosynthesis to primary arthrodesis? So which one works better in biomechanically and as well as regarding outcomes? So is there a study in the long term. So could you mention the study for us?
There are two randomized studies that cover this, and unfortunately, they both go each way. So it doesn't give you a definitive answer. The Sears one is the one that I basically use to support my practice, and he showed that primary fusion for the medial column gave you better outcomes than doing bridge plating or temporary stabilization. I agree with the previous speaker about the idea that we know that the outcomes are primarily linked to the anatomical reduction of the joint. So I would agree with the previous speaker that actually it needs to be anatomical reduction. You can only get that by opening this up. As to whether you bridge plate or whether you fuse, the literature is definitely split. And this will be a great one for a big study. You guys in India have got the perfect setup for this. It would be a really good opportunity.
Yeah, so there have been a couple of trials who compared head-to-head primary fusion with this kind of in this kind of injury versus fixation, and there are obviously, as Dr. Fraser pointed out, there are pros and cons of both. But there are some evidence that people coming in for repeat surgeries after primary fixation is more obviously coming in for remaining a bit more painful. So functional scores are not that great after fixation possibly. And more people come in for second surgeries after fixation. And obviously, but we still don't know probably. So this is how it is at 6 months. And that is the standing X-ray. You can see the subluxation there and the collapsed midfoot there on the standing lateral X-ray. And you can see the hyperpronation there, and clinical pictures, you can see the herniated forefoot, there's a disturbance there, and a collapsed medial arch and the hindfoot valgus there on the back side. So that is how, obviously at this stage, there is no doubt, it needs a medial 3-column fusion. So that's what we did, a medial 3-column fusion by single midline approach centered on the second metatarsal, saving the cutaneous vessels there, the extensor hallucis brevis tendon, incision on the fascia of the tendon, the muscle of extensor hallucis brevis is retracted onto the medial side, and then, possibly missed that, and then the joints are exposed, and then obviously you do your maneuvers for fusion required small joint distractors, and unless we use that, it's not possible to do justice to these joints. And we retract the joints with small joint distractors and use blade osteotomes, or even in old cases, osteoporotic bones, even a knife can be used to take out the cartilage. And then we fix it with the plates. So that is repeated for the medial 3 columns. So we basically at this stage, there was no option but for fusion. So we fuse this. It's about 6 months down the line, the fusion is healed, and these are post-operative clinical pictures with restoration of the abduction. Forefoot abduction has been corrected, bit of an arch has been created, and the hindfoot valgus, as we saw preoperatively, has been corrected. And that is 6 months down the line. That is how this young patient now walks. So that is my second case. Anybody would have done anything differently? Any comments, Dr. Sampath?
Oh, I fully agree with you, sir.
Wonderfully done, Dr. Rana. It's a great job.
Midfoot fusion results, even functionally, they are quite better. I mean, even they have reported at least they go back to the athletic activity. So, middle column midfoot fusion, they are really rewarding.
Even for the younger people nowadays, the people are, as Dr. Fraser and Balvinder probably will agree, that even in the phrase cases, people are now going towards the fusion and they are recommending the plate to be removed early. Fraser, how do you recommend your patients to remove the plate by around 9 months, 8 months? What is your recommendation in your hospital?
Well, it's funny that because when I first started, I was removed after 6 months. I've not removed the plate now for about 2 or 3 years. So I just,
Okay.
but it's a burden on the service, and I don't think it makes any difference actually.
Yeah. Here's a quick question to you: what is the return to sports ratio in this kind of patient, this kind of young athletes population that we have in Dundee, that you have come across?
Sorry, that question to me.
Return to sports, return to sports. All in
so I would normally say at 6 months they should be fine to return, and they're back into normal footwear at 3 months. So,
And Dr. Fraser, what about the skin infection rate? Infection rate of skin breakdown in these cases? Because some review literature says that in these cases there are some incidents of skin breakage or infections. What is your experience about that?
So interesting enough, as you know, we do proms for every patient we operate on. This group would have come in my elective practice. I think I reported them actually. I just saw them on Friday. 78 cases. I've had one deep infection in that group of 78. So it's not 100. It's not 100 patients, so I can't tell you, but that's probably about right. I don't think the plates cause too much trouble. Actually, I think the newer designs are much better. We moved from a company called Biomet because they're a little bit bulkier, and to a new company that have a much better profile. And I've certainly found them much easier. I have not had to take any plates out.
I think in these sort of cases, Professor Anand Pal, he has got a huge experience because he is probably receiving the huge number of foot injuries over that because this is the premier. Professor Pal, can you add on something? How you take this, whether you are advised to remove the plates, yes or no?
Yeah, actually, in my cases, what we have found that there are several soft tissue combination, and sometimes there is some large ecchymosis, especially on the medial side. So actually, we prefer the screw, that is the Lisfranc screws, that is from the base of the second metatarsal to the medial cuneiform, and also another cross screw that is in a cross manner from the first metatarsal to the middle cuneiform, and that is for the immediate setting. But if it is a very late cases like that, so there is a 3-column fixation is the only way. But for those cases, those who are very injured in contact games, so after at least 18 months, actually, I removed that plate. 18 months. 18 months, actually, I always allowed the patient to start the outdoor games from 6 months onwards. But most cases, those footballers, those who are especially those who are they are playing in a striking position, that is, they have to play very, very large, they have to shoot out the ball for long. So in those cases, so there is a possibility of some impingement syndrome. So there's some complaining of pain later on. So we advise them to remove the plate at least after 18 months from the date of operation.
Okay.
Dr. Balvinder Rana, quick question to you. Could you, for the benefit of the audience attendees, could you please highlight your post-operative protocol in these cases briefly?
So I keep them in a splint for about a couple of weeks till the sutures are out, and then once we remove the sutures, I remove the splint and put them in a compression bandage and remove the bandage every day and start mobilizing the ankle and the subtalar joints early on, but without weight bearing. Obviously, I would start a weight bearing at about 2.5 to 3 months. Once we achieve some union in the X-ray, there is an evidence of ongoing union. Partial weight bearing at 2.5 months, at about 10 weeks down the line, and then coming on to full weight bearing at about 4 months. That is that, and I would use a medial arch support for a fairly long time, and install with an arch support for at least 6 months to a year after surgery.
I think as swelling and edema control in the initial months, that's a huge problem with issues that I have found operating these cases. So they end up with a huge swelling. So that's one thing need to be taken care of. Right. So
in that. So in all foot surgeries, typically after the stitches are removed, I keep my patients in a compression bandage to control the edema.
Yeah. Thank you, sir. Thank you for your excellent presentation. I think we'll quickly switch over to Dr. Rajiv Shah in view of time. So, Dr. Rajiv Shah, sir, can you start your case presentation, your screen sharing as well?
Yes. Good evening, everybody, and thank you very much for giving this opportunity to me. I hope I'm audible and my screen is visible.
Yes. You are well audible and visible. Okay, make it just full screen.
Yes.
Okay.
So, this is the first case, and before I start my presentation, let me acknowledge that we are having 2 past presidents of Indian Foot and Ankle Society with us. Not only Balvinder, but SAMPAT DUMBRE PATIL has also been our president just a year or 2 back. So, this was a 24 years old dentist who had this kind of a compound trauma. I don't have the initial injury picture, but it was 2 days after the trauma. He presented to orthopedic surgeon, and orthopedic surgeon did debridement, external fixation, with two K wires which were passed from calcaneus to talus to ankle like this. And then infection sets in because this was to be operated on day 1, which got operated on day 3. Surgeon did debridement number 1, surgery number 2. It failed. There was persistence of infection. Surgeon did debridement number 2, surgery number 3. He removed the K wires, and it was at this juncture with this kind of a clinical picture with patient in toxemia presented to a foot and ankle surgeon. Dr. Sampat, how would you go from this point onwards?
So good evening. Obviously now when infection is there, we need to first tackle infection with thorough debridement, and it should be thorough till bone. Soft tissues needs debridement, loose dead pieces of bones need debridement, and of course along with that, if patient is in septicemia, we need to manage him as well. But other than antibiotics, he needs thorough surgical debridement.
Yeah, I agree, because you would never rely on somebody else's debridement. You would always like to go in, have a look under your own eyes. So that is what I did. Yeah, please.
So I said the second look.
Yes, second look, exactly. So I went in, I did the debridement, I excised the dead bone, and there was defect of 12 centimeter. So this is a defect of 12 centimeter with tibia above, calcaneus below. Dr. Samanto, how would you bridge this defect?
At least show one clinical picture. Because you see, because now the defect is like a huge one, is a 12 centimeter defect, and only the piece of calcaneum is just left. I think
full calcaneus is there. Yeah.
Full calcaneus is left only. Okay.
Yeah.
So if you want to salvage this, there is only two ways. You can transport the bone by Lizarov, or else you can do your TTD sort of nail, and also you can graft it. But problem is the infection. Here you have to take care of the soft tissue first. X-fix and soft tissue.
And a big defect. Can you bridge such a defect with a shortening, doing TTC nail?
No. I think we are not just going ahead with just to bridge the defect, just for the stability's sake, because you have to give some stability to this fragment. Otherwise, any soft tissue procedure you cannot do.
Yes. So that is what was done. So
Lizarov, yeah.
Yeah, we went in with the Lizarov fixation, and a corticotomy proximally was done. We started lengthening. Some plastic reconstructive procedures were also done for the skin coverage. Infection was getting under control, and it went on. And then when it came to the level of docking, we went in and did the bone grafting, and ultimately it united with this kind of position. Balvinder, any further management would you do with this patient? Or you would just leave him like this?
Further management means from now on, you mean?
Yes.
So I would want to see how he stands and walks, to take a call. How is the pain? Is the foot plantigrade?
Foot is plantigrade. Foot is plantigrade. He is able to stand. He was able to stand, and that's why the fixator was dynamized and removed. So, would you call it a day, or would you do some further management?
Problem is that this even when he starts working, then probably it might fracture even.
Exactly.
It is very difficult to carry on this up to this level, because there is a lot of soft tissue on the posterior side, and the bone is very, I think it will not be enough to carry weight. So it should be protected. Otherwise, it should be give some graft on the lateral side also to make it consolidated between the tibia and fibula.
So how many months should it be protected?
So at least 9 months.
At least 9 months to 1 year. Yeah.
9 months to 1 year. Okay. So here comes the main reason why I brought this case. This patient was protected with a Biloni brace for 15 months. And then one fine day, he comes with some kind of instability, complaints of painless instability and repetitive fall. This is the X-ray picture,
Yes,
and,
final.
that is how he walks. Oh, why is it not working? Sorry about it. But he walks with his foot drifting into valgus. Dr. Fraser, what would you do at this juncture?
Well, this is a difficult one. You'd be counselling the patient now. You've got to have in the back of your head. This could get fairly serious. This guy looks like he was a young guy who was a dentist. He was
24 years.
Yeah, so you've got the option of trying to fuse this with bone graft, and probably it's a. Would you do it with a nail? Probably I would do it with a nail. You've got fairly significant soft tissue trauma around this area from before, so I think it's going to be very difficult to access this without causing more trouble. I used to have a colleague, Mr. Jain, who worked in Dundee, who many of you may well know. He was fantastic with amputation, and I suspect he'd have been talking to this gentleman about baloney amputation. But I think I would desperately try to get a hindfoot nail up there with bone graft.
Balvinder, your viewpoint?
Yeah, obviously I would. This has to be fixed and bone grafted, so I would do a hindfoot nail in the corrected position, prepare the area again, do a bone grafting, and do a hindfoot nailing. I think that is a choice. It has to be fixed and bone grafted. That would be my choice.
Sampat, your viewpoint?
If the foot is sensate and plantar skin is good, then it is worthwhile giving him a chance to have a sensate foot. And in the first place, when we do bone transport with Irizarov, did we prepare the calcaneal facets, sir? Because that union...
Yes. So when it came to the level of docking, we went in and we pushed in the bone grafts and we compressed, and then we kept apparatus. So in fact, we went one step ahead of putting a bone graft also.
Yeah, that means now, if at all we are doing, then we may consider something like intramedullary fibula, or because we have already done bone graft and some additional bone union. So we need to discuss with patient that once bone graft has failed, so does he want straightway Biloni amputation or some salvage procedure like TTC fusion?
Samanto?
Yes, I told like two options. One is Irizarov, another one the TTC. The TTC is now coming the second, because if we want to salvage this foot some way, because he is a colleague of ours and probably he will be definitely the skin looks good at the last X-ray, last clinical picture as you shown the view. So I think we have to salvage by the TTC nail and graft.
The issue with the TTC nail for me was like you getting one transverse and one posterior anterior screw in calcaneus.
Yes.
I was not so much, confident of giving a stable fixation with TTC nail. And so this is what I did. So I went in through the lateral approach. I did the fashioning. I put in a lateral plate and I did a bone grafting. And this is how it went on to unite, and he has gone back to all his works. Any comment?
Yes, this is because now you need the stability. So you have to do either with this one or else what you feel best. That so this is another one good option so that you can go. But problem is this sort of plate is that you are really worried about how you go with the soft tissue. You are lucky that if nothing has happened to the soft tissue because the clinical picture we have seen, the soft tissue was really big worry. True, Sampat?
Agreed, sir. I mean, soft tissues that have accepted internal fixation is really good. And in this case, if at all it allows, we can even put an intramedullary fibula as well along with the plate.
Yeah, but then fibula, going for fibula, this was the area through which you would have been going.
Yeah.
So that was the issue. Okay. So,
Okay.
Any other comment, Dr. Fraser?
Can I just ask a question? Your original showed the talar head, I think, still intact in situ at the time. Because that's if I looked at that before, one of the options there, if it's still there and present, is to do a Blair fusion and use the talar head onto the front of the tibia to maintain talar-navicular function to a degree, to at least give some mobility to the midfoot and forefoot.
Yeah, there's some part of it. I mean, some part of it was there, but I was not so keen on doing the Blair. It was a calcaneus and tibia portion.
Yeah. Otherwise, no, I think it's very. My Sheffield colleagues will be cheering because they love this plate, and they think it's a great option.
Rajiv sir, it's an excellent case. Can I get a quick comment from Professor Anandopal, because we do a lot of this fusion, ankle fusions in our medical colleges. So Professor Anandopal, would you have done anything differently to augment the fixation or to put in endosnil or put in a TT along with that? So your comments, sir.
Yeah. So actually, in those cases, what we have to done in our setting, we are very much afraid of the soft tissues and putting a internal fixation device in this manner where there is several scarring inside. So what we do actually, little bit, the initial part is okay. That is a laser to maintain the gap, to cover up the gap. So ultimately, what we do is a little bit shortening so that both the tibia and fibula will come in touch with the calcaneum. So in that case, we have to make a space in between the tibia and fibula with a huge graft, which will iliac crest graft, which will breathe between the tibia and fibula as also the calcaneum. So I think that that will be good enough without placing any implant in this manner, and little bit shortening at that. So a little bit shortening is beneficial in such cases than the actual correction of the length, which is very, very important. So in that case, first of all, we have to bridge the gap. There is one. Second one, see if there is any correction of the soft tissue. Soft tissue should be corrected in the form of the reverse sural flap or from the cross leg flap. That is one. So otherwise, if it is almost completely okay, it is okay. Otherwise, we have to fix both the column. There is lateral and medial column. That is with both the tibia and fibula will come in, will bring to close the gap between the tibia fibula remnant and also the calcaneum, and to fill up the space with a huge iliac crest graft to maintain with the help of the triangular frame, triangular apex for at least 3 months, followed by the PTP cluster. And most of all, we always keep the little bit shortening. That is at least 1 to 2 centimeter shortening from the sound side. And after the removal of the external fixator from 3 months onwards, we'll keep it in cluster for another 6 weeks to 8 weeks, followed by the boot with little bit correction. We keep always some under correction. That is usually suffice in our setting.
Yeah. So in this case, the important thing is that he's a young, unmarried dental surgeon who is not ready to accept shortening. Number one. Number two, soft tissues were quiescent for 19 months, and thereby this. Okay, so a doctor who sustained fall from second step a day prior had a closed injury. He was of 42. And she presented with this X-ray picture. Balvinder, what next for you?
So again, it looks like all five TMTs are gone, and looks primarily a ligamentous injury. I would want to see the skin and the soft tissues. And even if the skin and the soft tissues are fine, then I would obviously, and there are no other, what's that? So that's already she has had an amputation of the great toe, is it? Is she a diabetic maybe? Okay.
She's not
Anyways.
diabetic. She's not diabetic.
So anyway, I mean, she will need a primary medial column fusion and a wire fixation of the lateral two, the 3 medial column primary fusion, and reduction and fixation with K wires of the 4th and the 5th TND joints. Looks like the other bones are all right. Looks like it's a pure Lisfranc, but obviously I would do a CT scan to see that the cuboid and the other articulations are fine, and if they are fine, then this looks like it's a pure TMT all 5, then medial 3 column fusion with locking plates and lateral 2 column fixation with K wires.
So you don't feel that you want to ask certain other things? Are you not suspicious about something?
Artery.
Balvinder?
Artery. Rajiv, artery. Probably you are asking for the artery.
No.
Of the great toe, and the second toe is short, so she had some complication. That's why I asked, is she a diabetic? But obviously you want to look at why she had an amputation of the great toe, and there is an amputation of the second toe also in the past.
So I would tell you that she has the same on other side.
Okay, then it is a congenital one.
It's a congenital deformity then.
Congenital one, yeah.
So Balvinder,
Yeah.
I'm not a primary fusion man. Still, in this case, I'll go ahead and primarily fuse this.
Yeah.
Any guess why? Sampat, your take?
Yeah. If this is non-neuropathic foot and significant trauma, then probably even I will not go for primary fusion, even if it is a primary, not a bony injury. But still, my preference is usually to fix it and hope it is non-neuropathic.
So Sampat, I am also of the same thought process like you. So we are two here who are not a primary fusion guys, and there are two here who are primary fusion guys. But look at the point which I wanted to bring is that this is the injury which is sustained. A pathologist of 42 sustained this injury, fall from second step of this step. It was such a trivial trauma with this kind of injury is what I wanted to point. Such a trivial trauma giving these kind of dislocations. Are we people not inclined to think about something else in the body?
Is it somewhere I think, can I go back to the clinical picture, Dr. Rajiv?
It can be something like hereditary motor neuron, sensory motor neuron.
I think it can be, can it be foot drop sort of, what you are pointing, you might be knowing better than.
It's some sort of a neuropathy, obviously.
Otherwise, from a second step fall, this is a huge injury to have a second step fall.
Exactly.
Otherwise, she is having some neuro problem.
So that is what I wanted to bring to everybody's notice, and that is why I brought in this case. With just a stumble from second step, she sustained this injury. She had congenitally absent distal phalanx of both the feet, distal phalanx of the great toe of both the feet, distal phalanx of the second toe, ring fingers of both the hands were absent, and she had hyperlaxity of the joints. And these informations together with this pushed me to go ahead and do primary fusion of the medial column and K-wire fixation of the lateral column. So that was the whole reason that I brought this case. We have Dr. Balvinder and Dr. FRASER believing into primary fusion, so no more comment comments from them. But anybody would wish to comment on to this?
No, I think Rajiv, you have done a well done job because you have no other choice left. Because if she is having some neuro problem, you cannot go with the sort of fixation. You have to fuse it somehow.
Absolutely right.
And the lateral column has to be mobile sort of fixation, like the K-wires. That is the message.
Sir, a quick question to you. Sir, what is your, do you feel that a crossed screw for primary fusion compared to a breech plate, which is more biomechanically stable, which is more biomechanically sound rather, in terms of stability? So what do you find, cross screw with breech plating or breech plating alone?
Well, I don't have any study in front of me done by me to comment, but I am quite comfortable by putting first the less frank screw and then the plate, because these plates also have a possibility to generate compression through them. Like this plate which I've used, this is a R-crutch plate, and this is R-crutch plantar plate for the Lapidus fusion, and this screw itself generates a good amount of compression. So is here. So sometimes with these screws, they remain, the head of the screw sometimes remain prompt and may impinge, sometimes they break. So I am quite comfortable with the use of plate, which in itself can give rise to compression through it.
So, if I can say something on that, the problem of the fourth and the fifth, what's your option? Because many times these joints do develop arthritis after a bad injury. So it looks like in the post-op X-ray, the follow-up X-ray that we are showing, the fourth TMT seems to have degenerated. So
yeah. So what I've observed at that whatever degeneration you look in the radiology is mainly not matching clinically. So radiological degeneration may forerun the clinical problem. And I have had one occasion where I had put in a spanning plate between the fourth TMT and the cuboid, and which was then removed later on. Otherwise, I like to put in K-wire, and if at all there is some degeneration, it really doesn't matter. I don't know what is your experience. What is the experience of Dr. FRASER?
Some of these patients do have lateral pain if they develop lateral arthritis, and then you are searching for answers. So, Dr. FRASER's opinion on that, have you had a chance to treat a lateral fourth and fifth TMD arthritis post-injury, which is painful?
Yeah, I'm probably in exactly the same position as all of you are. With Dr. Shah, I think the majority of they have arthritis don't tend to be symptomatic. I have gone down the route of doing injections with steroid under image guidance, and that has bought time. I have got one case who I was planning to do an interposition arthroplasty for. That was my only get out. I haven't done it, and I haven't needed to. Thank goodness we've had lockdown because she's not
Okay, that's all from my side. Any other question, Dr. Dev?
Yes, I think Dr. Rajiv, you have excellent cases from always. Every time you come along with some excellent cases and rare cases too. So I think Nirmalya is in the loop. Nirmalya, Rajiv, can you hear me?
Yes.
Okay. So I think Sampat, you can go ahead with your cases. Sampat.
Yes, I can. So I will start sharing my screen, and what I will do, since we have discussed some TARAS cases and calcaneum cases, I will switch on to some other case where we can discuss the management and are you able to see my screen?
Yeah. Make it full screen, dear. Yeah.
So he is a 30-year male, and he had injury to both feet when he was landing from his parachute. And this was his right side. Obviously, right side has medial malleolus fracture and very bad comminuted talus fracture. Left side dislocated through ankle, but he had pretty bad midfoot injury as well. So left side you can see I was not involved at this stage. Right side they have put in fixator, and he's a young guy. And left side they have done some reduction and they have inserted K-wire. So I inherited him at this stage where right side CT scan shows absolutely smashed talus. It was beyond reconstruction. So this was talus on right side, and left side the midfoot was very bad. I don't think so that I have. Yeah. So this was how his right side was there. So what I will do is I will go through the case, and then I will invite panel to have their own opinion. So right side we thought, there was no posterior talus, so it was comminuted, and we were involved in the case almost after 3 weeks because of polytrauma. So we decided to go ahead with primary fusion of the ankle and subtalar joint with TTC nail, but then we could get reduction of the talonavicular joint, and this is how he went on to do well. We did not address the medial side because we were doing fusion of the TTC nail. This is how he went on to heal, and these are his pictures of follow-up. Now left side, look at this. His midfoot was completely dislocated, and his ankle was dislocated. So what we did, he had pretty bad comminution in the midfoot. We got his midfoot reduced, and that gave us reduction in the ankle. This time we went ahead. See, this was a bad midfoot. Talonavicular joint was pretty bad. So what we did on left side, here there was initial K-wire put. We removed it, and we used lot of chronos, and we did subtalar joint and talonavicular or midfoot fusion. We did this because then on left side we could reduce his ankle, because remember his ankle was also dislocated, and bilateral this thing. So I always do this. This is called a simulated weight bearing. So immediately we put him on the simulated weight bearing. He keeps on pressing at the end of the bed. This is how he went on to heal. Now look at this midfoot fusion, but ankle is restored. And on opposite side, we did TTC fusion, but midfoot was good. And here he went on to heal because there was a lot of comminution. We needed to use bone graft as well as chronos. This is his follow-ups on healing. And look at these both pictures now. On one side, we did TTC hindfoot fusion, but midfoot was good. And on the other side, we did subtalar and talonavicular joint fusion, but the ankle was good. Now see his, sorry for the audio. See how he functions well. See his follow-up after almost 7 years. Now he is back to his work, although not to the level, but he is now into training, and almost after 6 to 7 years. The point I want to bring is the foot joints are interrelated. So on one side we have done the TTC fusion, but midfoot is good, and on other side we fused the subtalar and midfoot joint, but then we could reconstruct his ankle joint. And this is how, playing with his biomechanics, he is back to almost his good work with bilateral fusions. So this was my case first, and I will invite panel to opine on it. Fraser, sir, any opinion on this?
Very impressive piece of work. I think you're on a hiding to nothing from the start, so that's I think that is pretty good salvage. This guy is very lucky to get back to where he was. Honestly, I don't think, I'm not sure I'd do anything different from that. I think the only thing I wondered about, from my perspective, is whether I would have gone early or whether I'd have gone later in terms of making the decision. Just to see what the bone quality is like, see if he develops AVN. And sometimes I've got a few patients who have got similar injuries, drug addicts, disappear, non-compliant, and they seem to do okay. So now whether that's drugs or whether that's the fact that actually some people are not symptomatic with this, I don't know. But no, that's hugely impressive.
Thank you, sir. Rajesh, sir, any comments from?
Yes. So, great job done. On the right side, I would definitely have not done TTC fusion. He's a young man. On the left side, we have salvaged the ankle. On the right side, if we can really salvage ankle and subtalar joint, it would be better. And nowadays, we have availability of 3D printed bone models, which we could go 3D printed talus implantation, which would give you a good ankle as well as subtalar range of movement. And the Eastern studies have shown that their custom-made talus prosthesis has survived for 35 years or more. So, yes, long-term results of 3D printed total talus prosthesis are yet to come, but they're quite stimulating. And you can always do TTC fusion if it fails. Right? So I would, on the right side, I would have gone for total talus replacement. And on the left side, you've done a fantastic job. I would have done the same.
Thank you. So only issue was here, there was very difficult pylon as well. And posterior part of talus was not there. And I was almost involved after 3 weeks of initial injury. And there was, you can see, the medial pylon is absolutely, beyond reconstruction, because even I went inside for some reconstruction, like only ankle fusion and can I salvage, but when I went inside, the medial platform was missing and almost half of the talus was crushed. So
yeah, can you go to your first X-ray? Even another option could also have worked, which I'm going to do on this next. Yeah. Maybe a CT scan. Go once. Yeah. So if you see on your left side on a CT scan, your half of the talus body seems okay. I was just thinking aloud. Could we have gone for a allograft talus, half of the allograft talus for this case? Yeah, because the salvaging ankle to me is of the prime significance. You can always sacrifice subtalar joint, that doesn't matter much. So on Friday, I am doing a case where I am using half the talar lateral body is there. There is a fracture of the neck of the talus also. So I am using a allograft talus to replace the medial half of the talus and then to reconstruct it with the neck and body. So that is also one other option. The bottom line is try to salvage ankle as much as possible.
Issue was, it was both sides involved, tibial platform and talus. That was the issue, I thought it. But it has given a good 7-year long.
Yes. Fusion is a solid option. There is no question about it.
Thank you, sir. Any comments from Balvinder, sir?
Balvinder has to leave, so he just requested me because he has probably left.
I'm here, but to my mind, it does not seem to be reconstructible with that kind of tibial platform damage. It looks like possible tibial platform and talus damage. I think fusion would be the primary answer rather than thinking about an allograft or a 3D printed bone model. If the distal tibia is fractured, I don't think fusion is definitely the answer for this. So thank you very, very much for inviting me. As Swarnendu said, I'll be taking your leave for something else. So thank you very much.
Okay, thank you, Dr. Balvinder. Thank you very much. Thank you for joining.
Thank you.
Thank you.
If you allow, I will quickly go for second case, which is, I thought, a little bit away from trauma. If Dr. FRASER agrees, I will quickly go for the second case because I should give him enough time as well.
Okay, I think Fraser should go ahead with that. Then Dumbre, I will come back to you then.
Sure.
Dr. Fraser, are you ready?
I'm ready to go, yeah. I'll just share my screen.
I will unshare space. Yeah, you can share your screens. I have unshared. Are you able to share your screen, sir?
Have you got my screen up?
You have to unshare.
Yeah, I did.
No, yes, now it is done.
Okay.
Now I think Dr. Fraser can share his screen.
Can you see my screen?
No. Yes, it is coming.
Thank you. So thank you for the opportunity to speak about these a couple of cases. They're a little bit different, but I thought they might be of interest, particularly. Let me just see if I can move. It is, yeah. So the first case is a lady who came to me a year before. She's a 30-year-old female. She's type 1 diabetic for around 10 years history, very keen on the gym. And I saw her just a year before her trauma, having just done some MIS cystectomies for little dorsal bumps, just a trimming of some bone, and discharged her happy with the outcome. She then presented with one of my senior colleagues, having had a week's history of discomfort and stiffness in her left ankle, just some loss of function, really. Can I open to the floor just to ask any thoughts, any plans about this? Dr. Shah, maybe Rajesh Shah?
What are her present complaints?
Just the fact she's lost function, got some stiffness and loss of function in her left ankle.
Okay.
Any X-ray?
Yeah, to me it seems like there is a bony projection at the back of the ankle, which could be a calcification in the tendon of tendo-Achilles, and she might have had ruptured her tendo-Achilles.
Okay,
I would like to know whether she had any previous history of pain and discomfort at the level of back of ankle.
No. So, interesting enough, she's not. There's no trouble at all. So my colleague at the time just made the decision to treat her conservatively. He put her into a boot and arranged an MRI scan for her. And that was the MRI result that came back. Note that the reporting radiologist said it had been an unfused hypophysis in the osteolysis. But clearly the diagnosis is this insufficiency fracture with a TA avulsion, which my colleague decided to manage non-operatively. So although functionally she was much weaker, she still attended the gym and still managed to continue to attend the gym. So she was discharged from that point of view. Well, she came back a month later with exactly the same history on the other side, but under my care. So, of course, I'm a medical surgeon, so I thought this needs to be fixed. And interesting enough, she always attended with her mum, and by chance, her mother was my midwife for my children. So there was a lot of pressure. I made the decision to operate, and I put in a combination of large screw and also these suture anchors, which are used to tie down. So it's a combination of two, assuming that she was going to have trouble healing. I put her in an Aquinas cast, and I converted her then at that stage to a boot, but I did always allow them to full weight bear. That was my decision at the time. And of course, she came back for routine review at 6 weeks. The top one is her left leg, and the bottom one is her right. So was I doomed to fail? Could I blame her for compliance? I don't think so. what should be my decision about revising this? I really welcome your thoughts on this condition. I'll open that to the floor based on experience. I'm not sure who's got the most experience with these.
So can you go back to your fixation slide?
Mm-hmm.
Yeah. To me, this was probably deemed to fail.
Okay.
Instead of one screw, the first and foremost thing for me is to screw will always cross the opposite cortex. Then only it is going to give us sound fixes. Number two, I would use 2 or 3 screws into divergent fashion to increase the pull-out strength. Now, obviously, I would cast in a equinus. But to me, one large screw which is not crossing the opposite cortex was something like inviting trouble.
Can I
Yes,
say
Sultan? Yes, Sabat, yes.
Can we see MRI, sir? And does radiologist look at the tendon condition? Because to me, rather than bone avulsion, it looked like calcification, which was really a degenerated tendon. So, in the first place, putting down that tendon, we won't expect bleeding. So many times, then we go ahead, excise it, and then put it with some suture anchors back to the calcaneum itself. But I agree, it is very difficult. I agree with Rajesh, sir. But one of the, rather than screws, if at all you want to fix up that bony chunk, what I found out was the tension band device, something like that, because whenever you are putting screws, you underestimate the coronal plane split in those when we put this inside the screw. And whatever you do, it pulls off, because Achilles is one of the strong, gastrosoleus is very strong. So I don't hesitate to even do little V-wile lengthening in, or little nicking in the triple section, hemisection in the tendon, just to weaken it, because below me it's very strong. And third thing is, because she doesn't seem to have any comorbidities. In comorbid people, if you are doing that late, I don't hesitate to even augment it with something else like FHL. But in such a young lady, I won't hesitate to excise this, put it back with some suture anchors, and will weaken the gastrosoleus still healing.
Okay, so I'm not sure, maybe the history wasn't clear at the beginning. This lady is a type 1 diabetic of more than 10 years duration. And she's a neuropathic patient. And this is a very rare insufficiency fracture that actually, when I got my senior radiologist to report it, said, oh, yeah, I've got a few of these in my bag, as it were, his history for teaching. And you'll notice this line that people talk about, this unfused apophysis. Well, that's not an unfused apophysis. That's a classic feature of an insufficiency fracture. And that's what this avulsion was. So, in fact, the fragment itself was, there was only a very small piece of bone to reattach on to the back of this bone. Of course, the bone quality was very poor. Interestingly enough, a paper has been published on this since this case happened, unfortunately for me, reviewing these cases. And they have tried all the combinations you spoke about, the tension band wiring, lots of screws, and in those cases, more than half of them failed in this group of patients. And they came up with they felt was the ideal solution was to use these suture anchors, but in combinations of suture anchors, and really excise the bone fragment from the tip of the Achilles tendon and reattach the tendon itself, so a tenodesis, rather than actually a repair of the bony fragment. That was their take on it. But this lady's got more for me to tell you about her. So obviously it failed. Should I have revised it? I made the decision based on my senior colleague not to bother revising it, because she did fine on the other side and she still attends the gym. So she did do that. But of course, I had to go back and eventually take that screw out because it was prominent, so more surgery because I intervened in the first place. On the left side, you can see bony fragments is flown proximally, but she's actually functioning very well with that. I obviously had to remove the excess bone. Of course, we know there are consequences for elongation of Achilles tendons. And so about 18 months later, I removed the metal, having removed the metalwork, she presented to me again, this time with midfoot sharp bone. So the mechanics of her foot have changed a little bit since those events. And then, of course, subsequently again, in 2019, she presents to me again with clawing of her toes. And of course, functionally, she's using FHL to maintain her balance and to as push-off now because she's lost her Achilles tendon. So clearly of me not dealing with this problem properly has been that she's now going to be a patient with me for life, I suspect. So, any questions on this particular case?
No.
It was new to me, and I've learned a lot from it.
Dr. Fraser, can I ask you a question?
Of course.
Retrospectively, when you are handling them late, one is to add little lengthening just to avoid too much pulling, or can you, if you are getting late, can you go for FHL transfer directly? I mean, rather than playing with this tissue.
Yeah, I mean that would have been. I think that would have been another option. Would have been going for an FHL transfer into her heel to give her a little bit more strength. My fear at the time was she was a diabetic, insulin dependent, very poor control. I suppose I was reticent probably because of the post-operative risk factors associated with that. Perhaps I should have been more aggressive and said, yeah, fine, just go for it. And I think you're right, the FHL transfer would have been a good solution for her.
Fraser, we have an excellent gait lab back in Dundee, if you remember, if you can reckon. So would the gait analysis and the foot pressure analysis would have influenced your decision in any way?
Yeah, it might have
about
been.
The management of the gait.
Yeah.
Yes, I was also.
It's actually a very good idea. I may even still take her back and see how she is functioning as it stands with bilateral TA, effectively lengthened TAs. So it'd be interesting to see how she functions. But certainly, I mean, if anybody else has got experience or advice on this, I'd happily take it.
Yeah, Professor Anandopal, we deal a lot of these kind of cases back in medical colleges. So can we have a quick comment from you, sir?
Yes, actually, I'm very much. I'm doing the same thing as Dr. Patil asked about it. So that is in those cases, this is basically a diseased tendon. It's a diseased tendon. Basically, it is a insufficiently fracture because lots of the patients are osteoporotic and diseased tendon. Tendinopathy is suffering for long period. So in those cases, there is some contraction of the tendons along with some abnormal bones. The bones are absolutely no value. So we actually remove that bones. Sometimes we give, if it is a fresh cases, it doesn't require some incision at the musculotendinous junction, but just give some traction, little bit traction, far operative traction, just for 5-10 minutes like that. So it is very easy to come back to the approximate the bone, the part of the calcanea, but to the cut end of the tendons. Otherwise, we will do little bit release incision at the musculotendinous junction, and then we fix it with the help of the bony tunnel, with the help of the Arthrex screw, or with the help of the tunnel to pass the non-absorbent suture, and we always will reinforce with the help of this flexor hallucis longus tendon. So that is our treatment options, and we protect it for at least 6 weeks, followed by the full weight bearing with the help of the wedge heel. That is for another 6 weeks. So total 3 months protection is, I think, is sufficient.
Excellent message, sir. Excellent.
Yes,
Great, sir. We'll let you carry on from there.
Any role of anchor?
Personally, I don't use the anchor, but personally, I don't use
Anchors are really too weak for this because he is diabetic and it's a big fragment. It's a deep and shortened tendon. It will pull out. That is the problem with the anchor.
That's true. By the way, just asking FRASER that regarding neuroma of these sort of diabetic foods, because earlier in our head of the department was very fond of the food analysis, asking FRASER. So regarding these neuromas of diabetic food, so his views about this, because we are not in India, we are not that much acquainted to evaluate all this over a food pressure or gait analysis lab regarding these neuromas of the diabetic food. So your views about that?
The brutal reality is we don't have time or really the money to fund it. We have that fantastic lab. Because of the clinical pressure, I routinely don't send my patients for gait analysis. It is used a lot for the CP patients, for cerebral palsy. For my group with diabetic patients, I just haven't got the capacity to deal with it as much as I would love to.
Thank you.
Okay. Fraser, can you proceed from here? Yes. So can you unmute yourself, please, Fraser? Can you unmute yourself?
Yes,
yeah, that's fine. Yeah, great.
Yes. I'll run through this relatively quickly because this is going to be common trauma, but it's just a little another point that I wanted to pick up on. This is a 56-year-old lady who fell down the last stairs of relatively low energy injury, sustaining an isolated trimalleolar ankle fracture dislocation. It was reduced in A&E into a reasonable position. Background: she was a smoker, 15 a day, and the admitting consultant at the time reported saying small posterior fragment, good positions, good soft tissues, should be fine for surgery following day. So can I just open this up to the floor just for an opinion? I'm trying to think who else would see it. Dr. Sampat?
Yeah, so obviously this is fracture dislocation, and the fibula, medial malleolus, and posterior malleolus has gone. Issue is now it is reduced, so we can take CT scan to plan it. But my clinical major issue is she is a smoker, so it's really an issue for healing. So based on CT scan, I will really be conservative in the soft tissues planning. Thanks.
Okay, good. So my colleague made the decision to take the patient to theatre. And actually, this was done the following day, not the same day. Just done with standard third tubular stainless steel. And you'll note there's a syndesmosis stress test done as well at the time. Actually, the reporting op notes mentioned there was poor bone quality on the operation. There was some crushing of the lateral fibula when the plate was being applied and the fracture reduced. They said otherwise adequate fixation.
Fraser, can you go back to the X-ray, please?
Yeah, of course.
Initial X-rays. Now, at this point, I'd like to ask our senior faculty, Dr. Rajiv Shah. Sir, what's your take on this? How would you proceed to manage this case? Your opinion, please, sir.
Yeah, so the only thing which worries me is her smoking habit. Otherwise, in a non-smoker patient like this, I'll definitely go in for CT scan if it is possible. Now I'm going to go ahead with a posterolateral approach in a lateral position to fix the posterior malleolus, followed by fibula, then stress the ankle joint, fix the medial side, again stress medially whether everything is fine, and I'm going to fix medial, lateral and posterior fixation. Posterior fixation with the plate, lateral fixation with the plate, medial fixation with tension band wire or screws.
Yes, Dr. Nirmalya, can I add something on that?
Yes, sir, please.
Yes, is that this is a trimalleolar, a huge posterior fragment is also there. Unless you fix this, you will be in trouble. And I completely agree with Dr. Rajiv sir that it has to be fixed with from the posterolateral side so that you can address both the fragments on there.
One more thing that this, just I wanted to share it because of my some bitter experience. This sort of patient should be very well briefed before surgery regarding the outcome, because these trimalleolar fractures in due course of time doesn't give you very wonderful recovery, and they are potentially victims of pull you behind the shoes, because I am fighting one. So I said that these are the, if you go by the literature, these trimalleolar fractures suits a surgeon, foot and ankle surgeon maximum. So you must brief these patients day in and day out before taking him for surgery about the outcome of these surgeries.
So Fraser, can I ask you? You haven't got a CT scan, right? So
Okay, good. So I'll come to this. So so I've completely agree with everyone who's every comment's been made so far. My standard practice is to always CT them. And actually, it's now part of the both guidelines for the BOA in Britain. We trying to push that through too. But it takes time to change, and sometimes it takes time to change views. So this was done, and fixation looks adequate, I think. Patient was put into a lightweight cast the following morning, discharged once safe, and then had a wound review in a week's time, or just about 10 days' time, with check x-rays done. Already, you kind of get a feel when you're looking at the x-rays. Well, in fact, I can open the floor, see anybody want to make any comment on the current x-rays, what they think.
Professor Anandopal, can I get you in at this point for your quick comment on this x-ray, please?
Yes. So that is basically, it is a supination, external rotation and injury. So there is a the plate which I am seeing, that is the plate should be on the posterior side. So in the lateral view, what I am seeing that there is a fracture is coming from anterior. This lower, it is starting from the anterior side. It is going up. So basically, it is posterior force is going on the posterior side. So it is better to be placed on the posterior side. So the plate is not, as it is not placed in the posterior side, that has to be protected for a long period till there is complete radiological union is there. Otherwise, that will, I think it will go into fade.
So based on your comments and also the comments of your colleagues, I would completely agree. So I'm a posterolateral fan. So I would go back, fix the back of the fibula from the same approach.
And the third malleolus was not taken care of. But I feel that the posterior malleolus was not taken care of.
Yes. The top point is once we have to see, once we have to fix once we go on the posterolateral side, first we have to fix the fibula with that either in temporary care fixer, and then we give just a posterior Drouet test to see whether under the C-arm and the fluoroscope, whether this it will give away the talus. That is the Volkmann's fragment, that is the fragment on the posterior part of the tibia, it is going back. If it is unstable even after the fixation of the fibula, that means that has to be fixed on. So so first of all, that has to be fixed by buttress plate, then the posterolateral plate on the fibula side, then come on the lateral side. I think this is my take actually.
That's the standard practice nowadays.
Can I make a comment also?
Even on the medial side, the screws are not
The screw is backed out. It seems that the screw on the medial side is backed out.
Yeah, screw is already coming out, yeah.
Good. So that's the other thing to notice. And you just wonder about the length of these too.
Length of the screws are very small. Even the thread is looking at the fracture.
And you look here at their relative position in the posterior aspect of the medial as well.
Yes.
In the fracture side only.
I'd like to ask Dr. Sampath, how do you feel about the fibular reduction to the incisura? You're happy with that? The fibular reduction to the incisura, you're happy with that? Does it look okay?
It is difficult to comment only on these X-rays, but of course he has shown a nice paste actually. But you have to see open. I mean, when you have opened it, it is better to see it is in notch.
Fraser, I would have liked 2 screws as lag fixation for the fibula. You can see a gap out there. There's only 1 screw across. I think that's another point.
Yeah, agreed. That would have been addressed by the posterolateral plate. If you could have lagged through the plate, and that would have worked very nicely. So this is 6 weeks, and you can see things are going badly here. The wounds have been absolutely fine. There's been no issue at all with her wound. But she's been full weight bearing. Against the initial advice, which was to be partial weight bearing in what was initially a cast and then a boot. So, what do we do now?
Can I ask Dr. Rajiv Shah, sir, at this point, sir, how do you proceed at this point, sir?
Yeah, so this point I think we'll need to go in and revise it before it fails. So the revision would again start with a posterolateral approach. Sometimes I do keep readiness to go with a posteromedial approach in this case, because when I'm doing the osteotomy of the posterior malleolus, where my osteotome exists medially, I tend to see through the posteromedial approach. So I'm going to go in with the posterolateral approach, do the osteotomy and reduce the posterior malleolus, again reduce the fibula. I'm going to use a posterior plate or an anatomical fibular plate, and also revision fixation of median malleolus with a longer screws or a tension band. But this do require revision fixation to me.
Sir, regarding this posterior malleolus plate fixation, do you usually under contour your plates to buttress this fragment?
I do under contour fibular plate if they are anatomical, but not with the posterior malleolus. Mostly it doesn't matter much.
Okay.
Posterior malleolus, if you just put on in the anti-glide mode, it will work. It is just has to reduce it, like
Hold it in the buttress.
yeah.
Dr.
It's just
Sampath? Dr. Sampath, sir, how would you like to proceed at this point?
Yeah.
Your comments, sir?
The only issue is clinically I will like to evaluate two things. One is her pulse, how is her distal circulation, and second thing is joint position sense, because since I am doing revision now, I should be double check about the vascularity and also, of course, the neuropathy, because the way it is failing, I don't think so it is failing because of inadequate stabilization. It is failing because of early weight bearing as well, because she is full weight bearing. I don't know how much amount of pain she has. So I would like to see these two things, because my next surgery should be a final surgery.
Professor Anandopal, can I get your quick comments at this point? Is there any clinical examination to tell us about the instability that she is having? Any clinical examination would you like to offer to this patient? Professor Anandopal? Yes. So Dr. Sampath has already highlighted that we'll see the joint sense. We'll also examine the pulse to rule out a neuropathic joint. So would you like anything to highlight clinically regarding the instability status of this patient? Because this patient is full weight bearing now, and we are leading to a failure if I am not incorrect.
Yes, it is clearly seen on the lateral view. There is a little bit more than 3 millimeter space is seen on the anterior part of the tibiotalar joint. So it is certainly it is unstable. So that is instability should be addressed first. So that has to be, it is right time to go in to revise all we have to remove all the instruments. First of all, we have to correct the third malleolus, that is the Wolfman's fragment, and to correct the lateral posterior and lateral subluxation of the talus first. And in that case, we have to sometimes we have to temporarily fix the tibiotalar joint with the help of the K-word, that will be a main landmark. Then come to the lateral side. We have to. It is very difficult to maintain the length of the fibula. It is very, very important that to see the talocrural angle, even sometimes in the paraoperatively with the dorsoplantar view with the help of the fluoroscope. So we have to maintain the fibular height. This is very important. And then lastly, we have to come on the lateral.
I think all the faculties will agree. To have a contralateral side X-ray in your theater to guide you to the surgery.
Exactly, the talocrural angle, that is the line between the talar surface and also the line joining the medial tip of the medial malleolus and the lateral malleolus. That has to be ascertained on the normal side. That has to be reproduced on that side. So unless you maintain the height of the lateral malleolus, then that will going to fail. Ultimately, that will lead to severe arthritis of the ankle joint. So that has to be. So first of all, we have to address the instability of the talotibial joint. That is the correct osteotomize on the Wolfman's fragment. We have to fix it in the proper position, then maintain the height of the lateral malleolus. With in that case, rigid fixation is mandatory on the lateral side. And now come to the medial side with the help of the longer screw by vertical fixation from the medial malleolus to the either posterior or the medial cortex of the tibia. That should be sufficient.
Okay, Fraser, can you tell us what you did from this point on?
So I did what you guys all suggested. First of all, was to get a CT scan. and it was very instructive. So this is really, from my point of view, that my main interest and gripe with my colleagues who don't get CT scans is because I don't think you get all the information about the posterior malleolar fracture until you get a CT scan. You can't assume it's just a Boltzmann's fragment. And I think there is a variant, this type, the Yamaguchi kind of 3s, where you see the whole of the posterior fragment malleolus is off, and it actually enters into the medial malleolus. And there is this group of fractures that I think are misunderstood, where you've got a biplanar medial malleolar fracture. And if you remember, she had her screws put in the posterior aspect of the medial malleolus. So the screw effectively split open the medial malleolus. So it's a posteromedial problem, is my take on it. Now, obviously, I'm happy to argue the point, but I agree with the idea of having medial lateral columns and getting the fibular length right and getting the rotation right. But I think it's also important to think about the medial side. So that was the reason I got the CT scan, and it was obvious to me that I think it was you can see that from the previous image that she's failing into varus. I think it's because of this posteromedial area that's not been addressed. So I added it to my waiting list as an urgent, and of course in the NHS that means I saw her 4 months later. So, which it should have gone on my trauma list, and to my eternal regret that it never did. So she has now clearly failed. She's got persistent pain and swelling. She's got neck pain. She's got resting pain. It's constant. The range of movement now is limited to 30 degrees. So now I'm in a really difficult position here. I'm going to show you what I did. I'm showing it really to be contained.
Before that, sorry to interrupt you, Fraser. Before that, can I get the opinion of Dr. Rajiv Shah, sir? At this point, sir, how would you like to manage this case, sir? Given the pain and the arthritis, pain on weight bearing, sir, your opinion?
Yeah, so obviously we'll have to discuss the options with the patient, but to me now, at this juncture, probably she's heading for arthrodesis. Before that, I wanted to comment that for a trimalleolar fracture, which are very severe variety, I do 2 things. Number 1, I paint and wrap both the lower limbs. Yes. That's 1. And number 2, I always keep the lateral X-ray of the opposite side on my view box. That helps me to really compare. Okay, Professor.
Very useful.
Okay, Dr. Sampat Patil, how do you like to proceed here? 4 months down the line, she is having a lot of pain, weight bearing.
Again, same
in your clinic now.
Yeah, I think I will give her option of fusion, which is more predictable, and osteosynthesis is less likely at this stage.
Yes. I think now the osteosynthesis is out of question in my hands, because this is too much of this irregularity at the joint surface. I think cartilage is completely gone on the tibiotalar side, so it is better to go with the arthrodesis. So, yes.
So I think fusion should be the answer now. I think it should be go for fusion.
He has already done that removal and arthroscopic. You have done
arthroscopic fusion.
Arthroscopic fusion. So I agree with you completely. I felt terrible about it having to delay, because of the delay. I think I had some responsibility for that. But also,
just asking, fibular side, fibular talar tibial side, is that satisfactory, or I think there should be something else has to be addressed? Like
for the fusion.
For the fusion, lower end of the fibula and the talotibular aspect, because there is some potential gap which has been seen. Can we ignore this, or we should address this?
No, so with the arthroscopic fusions, my standard approach, and its approach recognized, is to
that's no issue if we leave this. Just it's for my curiosity, I wanted to know. So if we leave this space, so there is no trouble for that.
Yeah. Okay. Thank you, Fraser. This was a nice case. Excellent discussion. So I think we can go ahead with Sampat's case. We'll finish, because already we have crossed 2 hours. So after Sampat's case, we can finish. Yes, this is full screen now.
Yeah.
It is full screen.
So-
Sampath, okay, go ahead.
So now I quickly go through this case.
Yeah, quickly.
He is a elderly diabetic person, and he has a wound on the medial side, and he comes to us with this wound which was draining over 6 weeks, and we could see some bone projecting out of it. Actually, he was referred to us for amputation because we were draining and we could see bones from it. But he was keen on salvage. Of course, we take his consent, and what we did was we excised his. Actually, look at his X-ray. His midfoot is completely dislocated, and these were his cuneiforms which were popping out. So what we did after talus, this is almost navicular. After navicular, you can see direct metatarsal. So we excised all 3 cuneiforms and went through the plantar aspect, did this plating, and this is how we see now. This is all 3 cuneiforms gone, and but we could see this. We are excising these cuneiforms and debriding this wound completely. Through same bed, we have done plating. Plastic surgeon did skin grafting, and this is how it went on to heal. These are weight-bearing X-rays after almost 3 years, and now we have his follow-up. If I can run the video for you. Sorry.
Yeah.
This is his video almost after 4 years. Of course, we are giving him brace and medullary support, but we are able to salvage his foot with good alignment. This is his weight-bearing X-rays almost after 4 years. So, any comments on this?
Sampath,
These are Sampath. These are always challenging to salvage the foot.
Sampath, why you did not fix the subtalar joint?
Actually, I was afraid of those wounds, sir. I did this in this particular condition. I did this in same sitting where I excised this thing. Of course, it was a preliminary thing. I thought I will do something else, but he's so happy that 4 years he's coming from Konkan and he's every year keeping follow-up, and he's absolutely happy. Only thing is I continued his brace, but he's happy with the whatever plantigate foot we gave. So afterwards, I never needed to go something else.
So in a charcot foot, whenever I am going beyond talonavicular joint, if I am spanning the talonavicular joint with my plantar plate, I almost always pass 2 screws from non-weight bearing area of calcaneus to the talus without preparing the subtalar joint. So this gives an extra stability while subtalar joint is not moving and your fixation into the talonavicular joint remains well maintained, and you may not even require to give a long-term bracing. So this is what I do. Otherwise, a good case, excellent case. But I always fix the subtalar joint to avoid movements at the talonavicular joint whenever I span the talonavicular joint. Dr. Fraser?
I'm afraid I put my hand up too. I look after diabetic patients here, which was a mistake I made 3 years ago. And these are really difficult. I don't have we've had meetings here about these cases, and I think the general advice has been from my colleagues is more metal is better. If you're going to go for it, really go for it. And I just wondered here whether I might have gone for doing a complete medial column fusion. So 1, 2, and 3 to make it as robust as possible. And I agree with the idea Dr. Shah was saying, actually extend it on. I would put longer metalwork in, more screws in, and more plates. That's my only comment.
Yes, but the problem was the soft tissue. The soft tissue and the diabetic, and the bone was just projecting out. And I think Sampath, you have got the guts to address this by this way, because otherwise nobody will going to touch this.
Now, Swarnendu sir, can I quickly get Professor Anandopal here, because in medical field we see a lot of this stuff. So Professor Pal.
It is excellent done. It is excellent done. The same thing we do also. Just we have to shorten the column and we have to fix the medial side as much as possible, and see whether it is behaving. Whether it is then after that, if the pain is coming from the subtalar joint, then we do the subtalar joint fusion. Otherwise, in primary setting, we always reduce the column, and that is usually sufficient enough to decompress the soft tissue, followed by the plastic surgical procedure. We have to see how the patient behaves. If the patient behaves it is well accommodated with the help of some little bit art support and some accommodated food, and it is okay. Otherwise, we will go in and again for the pain. You address the pain which is coming from the subtalar joint or not. Excellent.
Professor
Anand,
Anand, I don't agree with you, because when you are spanning a talonavicular joint with one screw, the movement of the subtalar joint always gives loads over talonavicular joint. And mind you, these are Charcot cases. You want stronger, longer combination spanning fixations. You don't want a flimsy fixation. So, whenever you are spanning a medial column, whenever you are spanning beyond talonavicular joint, it is almost always advisable and accepted world over that you have to fix this subtalar joint.
You are right, sir. You are right. Actually, basically, what happens sometimes the wound is so very rugged.
There was nothing wrong on the heel. There was nothing wrong on the heel of this patient. You could have passed 2 cannulated cancellous screws from heel to the talar body or neck. There was nothing wrong with the heel of the body. So,
only issue is, sir, here I have not crossed the talonavicular joint because I have passed this space across the navicular and the metatarsal.
There is one screw in the talar head.
No, sir. You see this talus head is, I have kept it.
Then it is all the more weak fixation.
Yeah,
you
but
still
still,
spanned.
yeah. Only thing is, this was.
I thought that there was only one screw in the talar head, but then you should have spanned more.
Yeah. Only thing is, this was a primary fixation for healing. So once we get the stable bony tissues, the soft tissues also heal. That was my primary intention. I agree that in Charcot situation, double fixation, double rigidity, and double immobilization, I would have gone for that. This was primary, and fortunately it healed. The message is not that, I want to give is with this flimsy fixation everybody can walk. Issue is, even through those beds, if you go thoroughly divided, they do heal well if you get the biomechanics back.
Charcot's joints are completely a different story. In Charcot's, the basic principle they fix as much as possible. Am I correct, Dr. Rajiv?
Yeah. Exactly. So in this case, we could get out, but not that every case you would be able to get out.
So Dr. Sampat,
yes.
Yeah. Sorry, sir. Please.
I think we had great discussion with the really. We are honored to have this galaxy of faculties like Dr. Rajiv Shah, Dr. Sampat, Dr. Balvinder, and our own Professor Anand Mondal,
Dr. Anandopal,
and Dr. Fraser. So I think already we have crossed like more than 2 hours. So I think we can have the final comment from Dr. Harold, how we went through, and finally we'll take comment from Dr. Rajiv Shah, then we'll close.
Firstly, generally from the bottom of my heart, thank you so much for the invitation to speak to you and present my case. I've actually learned more than you have, I can guarantee it, because you've got some fantastic cases, and I know your experience is extraordinary out there in terms of the level of trauma and volume of trauma that you deal with. So I actually would like to have more of these sessions, but with more of our people listening in, because I think we've got a huge amount of them. So thank you very much. I really enjoyed that.
Yes, thank you, Harold, for coming. Yes, Dr. Rajiv sir.
Thank you everybody for bringing me here. The cases were excellent, and the basics should be kept in the mind that yes, you need to fix a unstable posterior malleolus fracture, you need to work on to Lisprang, you need to look into the talus, you need to give stability, try to salvage ankle. So many messages were given where they were very loud and clear. At the end, I would thank you all for bringing me here, and good night.
Thank you.
At the end, I should say one word, Swarnendu, that this was really a great effort for uniting University of Dundee and West Bengal Orthopedic Association. We look forward for further meets like this. Dr. Fraser, we would love to get back to you and take more time of yours.
So I think
Rajiv, it was so nice. Dr. Rajiv, it was so nice that you participated so nicely. Thank you.
We'll have a quick word from the industry because they have been.
Yeah, Vikas must be given a thanks. The industry should be taken in account. Who has taken?
Thanks to Alembic for organizing it. Vishwanath, your quick words.
Yeah, thank you very much for giving us opportunity to connect with you, and especially Dr. Mr. Fraser Harold from University of Dundee, and thank you very much to WBA Association and to entire faculty for helping us to connect with you, and it was an excellent presentation overall and went very well. And also would like to thanks the entire participation. So
before we end up, we must have a talk from either from our president or secretary to end it up.
Yeah.
Dr. Chinmoy, sir, are you there with us?
I think both of them have they have not been
Arthur and
assigned.
Chinmoy, both of them are left, huh?
Yeah, I think we can conclude from our side. Thank you.
Yeah.
Thank you, sir. Thank you, sir.
Thank you, Dr. Fraser. Have a nice time. Hope to